Okay, that's 10 seconds on my end. So welcome to our December 3rd Behavioral Health and Wellness Advisory Council meeting. And Judge Blackburn, since you are already very, very visible, welcome you as our guest this evening. And you come up very early on the agenda, but we're going to get through a little bit of business first, and then we'll come right back to you. But just want to welcome everyone. Belated happy Thanksgiving wishes to all of you. Hope we enjoyed that, what felt like very early fall-like weather, and a chance, I hope, to probably get together in a very unusual and maybe limited way this year, but hope everyone had a happy Thanksgiving. Angie has roll, and in order for us to determine quorum, we're going to go ahead and take a quick roll. I don't know if you're able to do that, Angie, as you saw people joining, or if you need more time, but let's go ahead and...
We can do that, and then you're going to need to do the motion to conduct.
Yeah.
Okay. Dr. Vero, just please say present or here.
Right.
Monty Burks?
Here, present.
Sheila Calloway?
Here.
Dan Eisenstein?
Here.
Robin Nobling?
Here.
Jamison Norton?
Here.
Mary Lyndon Salter?
Present.
Pamela Sessions?
Here.
Dr. Stovall?
Here.
Dr. Webb? Let's see him. Pam Womack? Katina Beard? Shotzi Brunner. Okay, we do have a quorum.
Okay. Then since we can conduct business, I will entertain a motion that our council can conduct this meeting remotely tonight by way of video conference. So someone will make that motion and second that motion.
So move.
I'll
Thank you, Jeff.
second. Okay.
Pamela, thank you. All those in favor, aye.
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 Any opposition? Okay, then we will conduct ourselves by way of video this evening. Thank you. Look, on behalf of the mayor and the mayor's team, we really just want to take pause right now and thank each of you just for your continued work during this pandemic. I think it's obvious to all of us, regardless of how and where we are serving, that, throughout the county, larger metro area, we absolutely been delivering uninterrupted healthcare and behavioral healthcare, to residents of Davidson County and beyond. And we just want to make sure as a group that does not go unnoticed or unappreciated. We know right now, Jeff, Jamison, you may want to say more about this, but we know we've hit a period in this pandemic that I think many people feared early, that we're hitting capacity issues in our hospitals and many of our acute care settings. We're seeing the impact right now on staffing. We're having staffing shortages. So the impact is here. We're dealing with it. We're doing the best we can, and I think we are doing an absolute amazing and stellar response right now in dealing with this pandemic. But we know it's taken its toll on organizations. It's taken its toll on individuals. Again, I just wanted to pause long enough tonight to express our personal appreciation as a team. And I think we share that with one another, but also appreciation on behalf of the mayor and his collective team for the efforts that continue. And I know too, as we see what's happening, we're all bracing for what maybe can be a worsening during the upcoming holiday season.
Well said, Bob. Thank you.
Yeah. So I know lots of us have, it's our workplace, but it's also our family members, who are out there delivering healthcare services. So I know I recently got a call this week from the Commissioner of Mental Health. So, we're seeing it, right? We're seeing it in all settings as our institutes are feeling the stress and the burden right now too, especially from the staffing perspective. So whatever we can do to support one another in these efforts, I know that we are doing and will continue to do, but it's really going to take a collective effort to make sure that we keep this system in place for our most vulnerable populations during this pandemic. I think we've done a phenomenal job across the state, especially within Metro, to keep mortality low, to keep our response high, and to make sure that we're delivering the most efficacious care that can be delivered during this time. So just really proud of what I see happening in the county, throughout the state, but also from the delivery system of those members sitting here at this table, this large virtual table tonight, from council members. So thank you. Thanks to Dia, put out a nice little reminder when Angie and I were obviously prepping for the meeting, just to take a moment too and look back at the first 6 months of our work this calendar year, for some of the things we really want to recognize together as accomplishments this year. Let me go through a few of those before we go into approval of our minutes, and then get Judge Blackburn front and center this evening. But thinking about what we've accomplished since the beginning of this calendar year, let's not forget the work we did for the COVID-19 CARES Act recommendations. We spent significant time, I hope you remember, as a committee, bringing those recommendations together, formulating then the recommendations that would come by way of this committee's recommendations. All of our thoughts, all of our words were reduced to writing and put into a nice document that was submitted to the mayor at his request. Again, I hope we look back at that with a sense of a purpose and something accomplished early in the year. Recommendations to the Policing Policy Commission. As you've read the Policing Policy Commission report, I sure hope that you absolutely recognized the recommendations that came out of this group. And that same way, a couple of meetings together, the independent ideas that were submitted, the time we spent together to formulate those recommendations, and then Judge Blackburn to make sure those recommendations were submitted to you at your invitation to this committee to put something tangible and actionable on paper so that you could make use of it. And we absolutely appreciate the way you took our recommendations and made sure they were worked into the Policing Policy Commission recommendation. Also want to recognize the work that continues to go on with engaging the overdose response and surveillance initiative. Jameson, Jeff, special shout out. Jameson, really appreciate your recognition that the data, that the work that Vanderbilt's doing as part of this response. We all know you've been there, you've been providing emergency response, you've been providing follow-up, but your commitment to make sure that Vanderbilt's contributing to that database is absolutely invaluable for the community. I want to recognize your commitment to do that and to ensure that it gets done. I know we're still in the process of working out all the connections necessary for that, but looking back this year, first 6 months, your commitment and the work that's already in process, moving that forward, is something to be recognized tonight as well. We're going to spend some time tonight talking about the first of its kind behavioral health provider survey on the impact of the pandemic, the impact on both providers, but more importantly, the impact on those we serve in Davidson County. So Dee is going to talk about the early results of that survey. I want to recognize that tonight as well. Angie, anything else to highlight before we good? All right.
I did want to just mention that you did get the update of the overdose surveillance data. And, as Bob said, Jameson, thank you so much for all your efforts to make sure Vanderbilt gets included. And it's our understanding that should, hopefully, when we get data next month, that we will have some information from Vanderbilt included. But I know that these things take a while sometimes. But again, Jameson, I think your phone call the other night or during the meeting may have really helped to move things along. So appreciative of that, so that we really have the true picture of what's going on in the city.
So all of you have copies of minutes. We have two sets of minutes for approval tonight, October 1st and October 8th. The October 1st meeting, remember, was a regular meeting of this council. The October 8th was a special called meeting as we were pulling together those recommendations for the policing commission. I'd like to take those minutes collectively with your approval. So a motion to approve those minutes both from October 1st and October 8th. I'd like to entertain.
So moved.
This is Robin. I'll second.
Okay, Judge Blackburn, so moved, and Robin, thank you. All those in favor? Aye.
Aye.
Aye. That was Judge Eisenstein, wasn't it?
Yes.
That's good. I appreciate it.
Thank
I'd much rather be Judge Blackburn. She's much smarter than I. Thank you.
Any opposition? All right, thank you. Well, now I can welcome Judge Blackburn. So Judge, again, thank you for being with us the last time we were together as a council. Appreciate the insights that you brought to this group that evening about the work that was before you and the larger council, but we especially, again, appreciate your direct invitation to this council to provide you with our recommendations from a behavioral perspective for the unique work that was before you and the group. So we obviously asked you to come back tonight and share with us what you are able regarding the work, the report of the commission, and especially this group's recommendations. So thank you for joining us.
Well, thank you for the invitation. I want to thank each of you for the support you provided in getting CIT into the final document and the suggestions you made and the questions you allowed me to pose to those candidates. They really strengthened the proposal. And I will have to tell you, Dia helped me wrangle Noah. Noah is not a proponent of CIT. And as we were going through the final discussions, there was a Noah representative who was very hard-nosed, and without Dia's support and assistance, it was a challenge. So Dia really stepped in and helped me wrangle her that last conversation. So I really appreciate Dia's support and assistance. As you know, you've read the commission's report. CIT is in there, thank goodness.
Yes.
And I'm really excited about that. That's such a tangible piece of that proposal. And it's a step we can take that's going to make a huge difference in a relatively short period of time. I sent a letter to the chief today telling him that I'm willing to help him in any manner possible to get the funding, working with Ellen Abbott, the grant funding available through SAMHSA to implement that program. And based on the timeline we looked at, the funding can be in place by September. If we get it applied for in January, that funding can be in place in September so we can move forward with that program. And there's no reason to delay it. And I wanted to make certain that he knew, I know the mayor knows because I've told the mayor that we've got the funding. We just need to apply for it. Whether Metro applies for it or whether we apply for it through the state. And I want to go about it in the most sure-footed manner. Let's not risk the opportunity of losing the funding. Excuse me, just 1 minute there. I'll turn that off. I know that the new police chief has cited in 2 different speeches he has given CIT, and I believe he's committed to CIT and understands the importance of it for his officers and for the community. And I think that's an important piece as well. Bob, have you heard him mention that?
Yes.
Okay. You had to be grinning when you heard him mention that.
Yes. And obviously we're all going to stay steadfast and watching how that evolves.
Yes, absolutely. I know there have been multiple attempts that you all have made, each of you individually, probably collectively over the last 5 years to get this accomplished. I feel like with the funding in place, which will make certain it gets done, with your help and with Ellen Abbott and everybody else on board, I think we can get this done. And with the chief, I think being a proponent of it, that's going to make it so much simpler. That's one less hurdle we have. What are your thoughts?
I just had a quick question. What was Noah's opposition, or why were they opposing?
They didn't give us any reason. They were just opposed, just generally opposed. And she was a mental health provider herself, a psychologist, and she was just a stick in the mud. How's that for the best way to describe her? Judge Calloway?
That's so interesting, because if they understood what it was really about, they would. I would think Noah is one group that would totally support it from the get-go. When you talk about Noah's, and from what I understand or what I know, Noah's like a good proponent against, defunding police and that kind of thing. So this, in my opinion, is just like the next. This is what you do when you defund police. You put in the other. Yeah, it just doesn't make sense to me.
I was shocked. I was absolutely shocked, particularly with her being a mental health provider, that she would be so in opposition to it. But she was a staunch opponent of it. I mean,
That's interesting.
I know, Banji, you can comment, but I think unless I'm misreading that, I think it may be some of the siloing of sorts is coming out of a real interest and investment in the co-responder model. Whether or not there's going to be a co-responder component. That's probably not probably. It's where the models are different. I think there's good efficacy to both models. Obviously, right, we've got support from different camps for those models. And again, unless I'm misreading it, Judge Eisenstein, Angie, others.
I've had some, Judge Blackburn, thank you so much for your work. I mean, you've accomplished in the leadership that you've done what a lot of people have been trying for years, more than 5 years, as Bob knows and Angie knows and Sheila and the rest of them.
You left
I think I've had some contact with Noah. They reached out to me a little bit, and what they're talking about, and it was in the paper, is in addition to CIT, is having another co-responder model such as Cahoots. I think that's what their position is. I'm not so sure. In my conversation, it was anti-CIT. It was in addition to CIT. And I know the mayor came out and said if the money can be, it was in the paper, can be provided to do another type of response system, that he'd be in favor of it. But I don't, maybe I'm reading it wrong, but I wasn't at the meeting and I don't know who you're talking about. But from some of the people I've talked to who've reached out to me, it's more of an add-on rather than a subtraction. Bob, is that sort of what you've heard or not?
Yeah, my interpretation too. I think Noah is supportive of the co-response. So
yeah,
I think it is. I view it as additive as well, Judge. I think it's a good perspective. It's additive. I don't think it's subtractive.
Yeah.
This is Robin. I actually had some conversation with NOAA folks around this right about that time. And they really are interested in a co-responder model. They were very strongly in favor of Cahoots. I think they were still concerned about uniformed police going out. I don't think they were as familiar with the enhanced CIT. I think their thinking was probably based on a standard CIT model. So I know they were very, very, very strongly in favor of Cahoots, but at least guys, and they are thinking, we're all thinking of a model that does provide enhanced support. And I really do also want to thank Judge Blackburn for everything. That was tremendous. Thank you.
Well, you all paved the way to get it done.
I think in the report, it does reference the co-responder with CIT. So, it's almost building out what Nashville needs as Nashville's model. So I don't think the co-responder component was at all left behind. It was clearly in there. So, hopefully as this moves forward, we could see, I would hope that the best parts, what will serve Nashville the best is what ends up actually, moving forward when it goes into operation.
Absolutely.
Well, my position, when I've talked to folks that have reached out to me, is that I see it, judges, as, and I've tried to impress upon those that have talked to me, that you need CIT flat. I mean, that's got to be done. But that doesn't exclude a different model that could be used along with that. But CIT, because police are going to get the calls. I mean, they're going to be 911 calls police are going to go to. If there's some that police don't have to go to or fall in a different category, that's a different situation. So the feeling I got is sort of like what Bob got, I think, hopefully anyway, is that not to fight CIT, but if there's another model that can be laid over it or included with it, that could be effective. And I see the more the merrier, more that we can come up with. But the first step was the CIT, and I thank Judge for making sure that got through.
So, yeah, anything else you want to share with this group, or?
I will follow up with the chief and see what we need next steps are to make sure we don't drop the ball.
Thank you. So I think, as you look at this group, obviously individually and collectively, we want to help. So in any way we can, help from, beginning with the education that's needed, regarding the model to design, implementation, we're here to help. So again, I think it's, if you'll help in ensuring that those resources are available, we'd be appreciative.
Well, I'll keep you up to speed as the conversation continues.
Thank you.
Thank you.
So hope you felt the embrace tonight. Thank you for your work. It is a watershed moment for all of us. You said 5 years, Judge. You're right. You missed 2 decades on that. It's been at least 25 years that we've been talking about. I mean, an awfully long time. So we want to celebrate it and watch its. We really want to watch its birth and developing from here forward. So thanks for all your work and getting us where we are.
I will keep you all up to date.
Thanks, Judge.
Thank you.
Nice to see you.
Thank you, Judge.
Thank you. Angie, to you.
Sure. Dia is going to provide us with an update on the behavioral health survey that went out. This provider survey really is a first of its kind survey. And really it's a beginning of discussion on how behavioral health providers are responding to the pandemic and ultimately may have implications for how the field might move forward in subsequent pandemics, or just how it's going to influence the service delivery once we move through the pandemic. So Dia is going to present some preliminary information tonight, and then she's also going to talk about what the next steps are in further analysis. So Dia, I will turn it to you.
Thanks, Angie and Bob. I appreciate it. Stephanie, can I have the magic wand, or ball as we like to say in WebEx land, so that I can share my desktop? I'm going to start with just if you'll give me a second here. Thank you, Stephanie. I want to share the survey tool. So hopefully what you can see before you is my desktop with the survey tool on it. And so that you can see what it looked like, we did mount this in RedCap. We did ask for a licensure category. We had, as you will see in the results, the preliminary results, we can see that not every organization is going to be licensed. The first section of the survey looks at program operations. So really trying to get an understanding of, sort of what the current headcount is, and then particularly in February of 2020 and how that changed over the first quarter of this year in relation to the pandemic. And then from there, so there are very specific questions around that. From there, we look at, how service lines have been impacted, rather negatively or positively. And then we transition into questions around service recipients, and starting with a look at the caseload levels for each month in the second quarter, starting at late first and into the second quarter. And really trying to get an understanding of how those caseloads, why they might have changed. And then get a better understanding of which groups, both in terms of demographics, as well as in terms of conditions, were present prior to the outbreak of COVID-19. And then as the pandemic hit, how those groups might have changed. And then from there, just getting a better sense of what might be affecting, what client issues might be affecting care. So from there, we do look at the telehealth platform. How did that platform look prior to the outbreak and during, and then what is planned in the next year? And then finally, we really round out the survey on the 27th question around what are the priorities in terms of service delivery, direct to patient, secure electronic mail, electronic prescriptions, televideo sessions, telephone sessions, texting services. So that's an overview of the survey itself. And I'm going to stop the screen for a second and move to a preliminary overview of the results. And this should always be easier than it is. Hold on a second here. There we go. All right. Okay, what you should have before you is a PowerPoint slide that talks about preliminary overview of results on the COVID-19 Behavioral Health Provider Survey. Okay, on this first slide, what we can see is that we had 7 respondents. I want to remind everybody that this initial fielding went out to the organizations of the Behavioral Health and Wellness Advisory Council. So all of you were contacted about this, as well as the Community Mental Health Systems Improvement, which has about 20 organizations affiliated with it. And the first question, of course, was around licensure. So what we can see from the results is that of the 7 organizations that completed the survey, 5 are licensed by the department. And primarily focus on mental health outpatient, with substance abuse outpatient as a second area of competency, and then some other areas of competency in that list of licensure. Next, as we look at client demographics, really, I think the only aha there is that, that there's shall we say, less organizations serving the LGBTQ community. Again, this is a very small sample size. So given that, this just tells us a little bit more about the universe that we're looking at. And when we take a look at client characteristics, what we can see are the two populations that are served the least by this respondent pool are youth who are homeless and veterans, and youth who are justice involved. Those with co-occurring disorders are being addressed, and substance use disorders, as well as adults who are homeless, are being addressed primarily by this population. Next, despite the small population, I do think it's sort of interesting as we get into some of the results of the survey to see, you know, were there changes in caseload? So when we look specifically at the question around declining caseload during the period of March through June of 2020, what we saw was 4 of the 7 saw declines in caseload. 2 did not, and 1 declined to answer the question. The top 2 reasons that emerged for the reason for decline was telehealth inability or unwillingness. So, you know, navigating the telehealth component, and then sheltering in place. What we saw in relation to the question on what are some of the characteristics regarding the caseload changes, and this was sort of interesting. I mean, these are very small numbers, but 2 organizations identified that their new population are those who are uninsured, and that 3 of the 7 organizations are witnessing increased acuity in their client base. The questions on technology are very enlightening. What we saw was that 6 of the 7 purchased new equipment. Most of those purchases focused on laptops and tablets. There was some investment in cell phones, some around video cameras. And then the other category, one organization said that they invested in internet, a new internet provider. So those are the kinds of investments that are being made. On the other half of the screen, what we can see is that in terms of planning for next year, 7 of 7 organizations are going to be fully equipped with televideo sessions. That is up by 3 from before the pandemic. So before the pandemic, only 4 of the 7 had televideo sessions. I think that is significant in terms of the behavioral health provider marketplace, just of the ongoing transition to a telehealth environment. And then the telephone sessions, that was another interesting area where 4 of the 7 prior to the pandemic were conducting telephone sessions, and that increased by 2 in terms of planning for next year. So again, you're starting to see this shift and a focus very much on televideo sessions and telephone sessions. In terms of the limitations of the survey currently is small sample size. We certainly do not have a comparative population. So there are no other jurisdictions that I'm aware of that are using the same survey tool that we are. We'd be happy to share it, certainly. And there's a little more digging and analysis that we need to do with the results that we have so far. I want to remind everybody that this is a formative survey in the sense that it has been structured so that we could release it again to another related population or at another point to look back on other quarters of this year to see how this has changed. I think one final comment I do want to make that these data don't present here is that 6 of the 7 organizations that responded all received funds under the CARES Act or the PPP. So I thought that would be important just as you look at the data tonight. And I'm happy to take questions.
Well, let's start with the thanks for everyone who completed the survey and acknowledge that it was no easy task, right, Janet? Especially if you were in the early pilot. So, and Jeff, really appreciate, right, twofold. One, willingness to pilot this thing to get the bugs out of it. And D, again, thank you for your work and those that you involved in refining the instrument. What's not visible at this level are the number of additional questions that are part of decision trees, right, as part of this survey. So very robust, an extremely deep dive into the heart of each of our organizations in completing this. So again, just want to acknowledge, very time consuming to operations staff and fiscal staff, probably sitting side by side to complete this survey. And again, with appreciation. Dia, you said it, great baseline, right? We have a survey now that is sufficiently robust that we can send out in the future, and we will. So we have comparative data to this initial baseline data, and we sure hope we get a larger response as it goes out, but not a bad start. And again, very appreciated. So let's kind of open this discussion about the data that you see here and opportunities for use of these data.
I have a question for the advisory council, which is there anything that's a surprise in here so far? And is this helpful information?
I don't know about a surprise. I think one takeaway for me, even with the small number, is what we're talking about are things that are expensive. We're talking about technology, revamping your internet service, getting cameras, getting staff trained. It's expensive from the technology I think that organizations have had to spend. And it's expensive in terms of staff learning new skills, speaking for myself, learning new skills that have taken us away from doing other things. It's been necessary as part of the transition, but a whole lot of staff time and effort have gone into doing something entirely different while trying to provide the same services. And Bob, I think you spoke to that in your introduction, but maybe we don't see that in here, but it's expensive in all sorts of ways, including Dia, the amount of time you spent in getting this pulled together. But I think it just reflects how organizations are having to do what we've always done while doing it in an entirely different way.
Well said. And we probably don't have that qualitative measure in here. I think we're all aware of it because we're living it. And it continues to change on a daily basis. As all of us are looking at, each day tells us about what changes we need to make, we're adopting. And then we start thinking post-COVID, what do we want to keep, and what will change by this experience for the future. And I think it's going to continue to inform our practice and our care delivery systems.
Mm-hmm. There is a question in the survey about how well did staff do with transitions in technology, and it was a very, very mixed experience. I think there were only 2 of the 7 who said they had no problem with the transition to technology. So that is, an area that is ongoing, I think, to your point, Jeff.
This is Robin. I will add, even though we didn't respond, as small as we are, we're doing exactly the same as everybody else. An 8-session class for caregivers that had to be taken online and trying to educate and bond that group the way that we would normally do. And thank you, Dr. Stovall, for coming out. It's the same thing you're all talking about, having to buy more licenses for Zoom so that we could do the added support groups that we are now doing. Just wrangling up, volunteers, everything. And so it's happening. I'm saying this just to say it's happening at all levels. It really is from small to big. And I think we're all doing it.
Well, this is Mary Linden, and my comments are somewhat based on a statewide representation of providers, but I do think that for a lot of smaller providers, which many of my addiction providers are, certainly, you know, 3 million, 1 million in revenue, you know, they didn't have the finances or the infrastructure to even be able to invest in what they needed. And so a lot of the things around technology and whatever, they really lost out on because they just didn't have the depth of financing or such to be able to do that up front. And then when certain programs got enacted, like CARES and even you know, some of the governor's programs, you know, you had to have spent money in order to get reimbursed for expenses, which they just didn't have. And I think they're feeling very left behind. So we're struggling to keep up with some of the investments that other providers have been able to make.
Important note, Mary Linda. Yeah, because much of what's out there cares, right, from the state level, federal levels as well. You're right, it's reimbursement. It's reimbursement for costs incurred, and then it has to be qualifying reimbursement. So, and having being in the middle of that process, it's also pretty taxing from, you know, organizationally, to make sure that you're properly completing all the requirements for submission. So, you know, there's always that administrative burden on top of all this. But again, grateful that a lot of that's there, but it does not, right? It doesn't impact all providers across the system.
And I think I had providers who were genuinely skeptical about, you know, even if they got the money, they were afraid they were going to have to pay it back if they couldn't justify it later. And then they couldn't afford to do that. So they just chose not to access the funds.
Yeah.
This is Robin. In Davidson County, there were some extra grants that were available for COVID that we didn't have those constraints, but those smaller counties, they don't have that available to them. Thankfully here in Davidson, there were some monies available through the FRIS Foundation, through CNM, that, you know, and other areas that we were able to access that were grants that don't have to be paid back. But not everybody can do that. And so, yeah, we've seen some hardship with some of the folks that we know in smaller providers.
This is Katina. I was driving and I was listening to Dia, so I didn't really get a chance to see the data, but was there a conversation or information around workforce development and access to licensed therapists to be able to grow the capacity of the organizations that are providing behavioral health services?
Hi, Katina, and I'm glad to hear that you're safe and sound, even though you're driving. We did not have a question about that, about workforce development, but that is certainly an ongoing issue in the industry. But that's a great question.
We need to work that in.
Yeah, I know in the rural counties, some of my colleagues are really struggling, and we are in Clarksville. We just took over the sexual assault services in Montgomery County, and we've been recruiting for therapists, and the pool of qualified therapists is very low. And then the training requirements around licensure is very daunting, especially for rural counties that don't have proper oversight and preceptorship for people working on their licenses.
Yeah, one thing that you know, as we've been on this journey, there's, I think, really 2 points that may be helpful. One is just how fluid it is. So as we talked about building the baseline at this point with the survey, it is a point in time, and to note that at different phases of the pandemic, we have adapted in different ways, and the preferences of our patients and population has adapted in different ways. And so it's important to know that it has evolved over time, even in the telehealth realm, and what types of services we're offering based on the adoption and the needs that we're seeing at different times throughout the pandemic. So I think it's good that it is a baseline and a point in time, but it is, even now as we've surged again in the fall, are significantly adjusting practices across of our services to respond accordingly for safety as well as for because of the preferences that we're seeing. The other thing to note is on the inpatient basis, and for whatever reason on that first slide there wasn't an inpatient option, but it's something that just to note. We're working very closely with the Department of Mental Health to devise a public-private strategy around COVID positive environments for acute psychiatric needs. And right now that really doesn't exist in a reliable form. Each psychiatric hospital generally has created contingency plans to be able to care for patients who are in that condition. But generally, whether because there's actually been lower volumes than we might have anticipated for many reasons, as well as just because of we're trying to create the same level of quality and support, and then training to staff and making sure that people are prepared in that environment to do good work. I would be interested among inpatient providers around those who have had COVID units and for how long in the volume, because it was something that we were struggling with to right size the needs on an ongoing basis to have reliable proactive units that could accept patients who are COVID positive, because we see a lot of these folks who are in emergency departments and other areas where they've identified as COVID positive, but there may not be a unit or the capabilities given the communal milieus that we deal with, and often having semi-private rooms and other challenges, group therapy, and being able to accommodate that patient. So, have been very impressed, and as we've mentioned, the collaboration that's happened across many psychiatric hospitals to help devise solutions and share resources and train clinicians to help get to that environment. And the commissioner is going to be rolling out this public-private partnership even tomorrow because of the work that's been ongoing. But this is, again, a fluid situation and strategy to help adapt to the system of care or the needs within our system. But those are some of the data points that we didn't have that were readily available.
So Jameson, I could see a question being added in other iterations of the survey that would say something to the effect of, are you a provider of inpatient residential services? How many beds did you have before the pandemic? How many
inpatient acute? I'm sorry. So residential's in there, but that's a different license, and it would be an important distinction.
Yes.
And would you want a follow-up question regarding beds, the number of beds prior to the pandemic and then during the pandemic?
I think what we'll see there, and again, is a very fluid response, is maybe did you open a COVID unit or isolation space over the course of the pandemic, and the relative volume of needs for patients who were needed acute psychiatric care in a COVID positive environment. We can work through the specifics of that question, but what we see right now is generally each hospital is opening those units as needs become apparent within the facility or within that system, but it will not stay open on an ongoing basis. It might close down and then open again 2 weeks later based on the progressing need. And so the reliability is not necessarily there, but we do see each hospital is building these based on their own capability. So some actually have negative pressure rooms and isolation units. Some have significantly large hospitals that have a lot of capacity and open beds that they could use that, but some are limited in staffing. So each area has a unique plan based on their resources and the environment that they have in those hospitals.
Good deal. Yeah, and I'll follow up offline on that.
Mm-hmm. Good discussion. Anything else about the survey questions. Again, we're about ready to do a deeper dive into the other rich data. Again, even though our end is a bit small, we feel like we have some significant data we'll take a deeper look at, come back with some more detailed results at our next council meeting.
This is great work. Really appreciate everyone's contributions as well as the initiative to get these questions out there. Thank you guys.
Thank you all.
Thanks. Thank you, Dave. So the agenda says we've got an update here on grief counseling. So pretty quick note. Angie, you want me to launch on this or?
Sure. Yeah, that'd be fine.
Look, we had an inquiry from Alive Hospice, and just want you to be aware of that. Alive Hospice was proactive in making contact with us. They really wanted to make sure that as council members, right, we're collectively aware of the additional resources that Alive Hospice has in place. I think, part of it's a bit of marketing, but it really is an outreach right now in a time of high need for the community at large, especially with regard to grief counseling related to COVID, and just the impact on individuals and families. So with that, our promise was to make sure that we had this discussion tonight. Encourage you, if you think you have a fairly limited view of the work that's gone on at Alive Hospice, take a few minutes and go to their website. I've known Alive Hospice for as long as I've been in the Nashville area, which was 1979. I think they've been here that long. And I had a rather limited, skewed view of the services at Alive Hospice until I recently had this conversation and then went to their website and realized the amount of not only services, direct services for grief, but even broader support services that are part of their continuum of care. Significant sliding scale, deep discount for services. So especially as we're coming in contact with individuals with limited resources and or services that maybe are organizations, it's not maybe a service that we'll provide directly, but you're looking for a resource. Add that to your resource list and circulate the word. These are really, really valuable resources, we believe, that should be more publicized. Let's get the word out. Take a look at what you say, and if you want to, make referrals, make that information available, please do. Angie,
This is Robin. On that note, I've actually received some calls, and I'm wondering how many of you have, from family members who are survivors of loved ones that they've lost to COVID. And I've specifically had a lady that was attending an Alive Hospice group, and we have referred to them before. They do great work.
yes.
But I've had more than one call now from survivors of family members. And I'm wondering if anybody is, we've been asked specifically, are we doing a support group for those folks? And I am wondering if anyone is doing anything as a group with these folks, because we're just going to get more of them. And so we'd be willing to, direct people to that. But the need's there now, and we're just starting to hear about it. So I'm just wondering what anybody is doing.
Robin, since my conversation, we're making direct referrals now, becoming more aware that they have some specific groups for COVID survivors. Okay,
good. Very good. Thank you.
Yeah, Robin, I would really encourage you to, make contact with them and just, have a conversation. They're very, interested in making sure that, they meet need in the community. And as Bob said, we're very proactive in terms of reaching out, recognizing the kind of the strength and the depth of this, of the BWAC. And so I think that would be a great thing, great opportunity you never know where these partnerships are going to lead, or these conversations can lead to partnerships. So.
Yeah, and it's something that we would be. I think the person that we talked to was about 2 months ago. She's called us again, but I think they've probably adapted. And this, like Jameson said, is a very fluid situation. So, I'll absolutely do that. Thank you, Ange.
If I can interrupt for just a second in terms of a variation of kind of post-COVID. I know at Vanderbilt, we're organizing a multidisciplinary approach to people who are more long haulers who've had COVID and now are having residual symptoms of any sort. So pulmonary is involved, rheumatology is involved, cardiology is involved, and psychiatry is involved too. We're just getting that off the ground, but that's another group that you may be hearing of, either among folks you already serve or even among staff. And I could get and pass along to the group sort of a contact way, but this is not exclusively for people who are already Vanderbilt patients or anything, though many of them might be. So it's really something that we're beginning to see now is what about those folks who, 6, 8, 12 weeks ago had an acute infection, but now, from my view, are having longer term psychiatric complications from that.
Mm-hmm. Jeff, you want to say any more about that? I know I've read some of the earlier research. Anything in particular? I mean, there are some numbers lately from New England Journal. About 18% are showing subsequent psychiatric.
Yeah, I think we're seeing two groups. One are people who didn't have any sort of psychiatric issues before, and I think 20% is a number that I've certainly seen too, primarily around depression and anxiety. And then a different group that really are having longer term cognitive impairment that may or may not be related to depression and anxiety. I think for the populations we are all already serving, we know that people with serious mental illness and addictions are high-risk groups who are more likely to be infected and then more likely to have a more serious course. So then, what's going to be the impact upon somebody who's had recurrent depression but have been doing well, and now are they going to be more likely to have a relapse of their depression or worsening of their depression? Clearly, we're seeing that in groups of people who have addictions. I've certainly seen it among those who have psychotic disorders. So I think we're seeing kind of de novo development of psychiatric issues and then recurrences and relapses for those who have pre-existing illnesses.
Could I put in a plug too? Sorry, I'm going to get a flyer to Dia or Angie, somebody to circulate. But the Department of Mental Health and Substance Abuse launched an emotional support warm line for healthcare workers back in May. And as of this Tuesday, that same emotional support line is now open and available to educators. So it's the same number. The flyer is now co-branded for both populations, and we're definitely able to provide some emotional support on the phone, as well as to refer people to many groups all across the state. Both of the line is a statewide hotline.
Thank you, Mary Linda. We need to make sure these, again, developing resources are in people's awareness. We know how to refer, we know, who and how and when to make those referrals and to whom. So.
Yeah, I would really encourage individuals as you develop these or as you become aware of them to send them to Dia, and then she can get them out to the whole group. I think it's a real valuable way that we can support the needs of the community because we're all going to get different calls, we're all going to get different things. So that'd be great if you all would be willing to do that.
Right. Anything else? Does everybody's agenda say BWAC transition? That's me. So let me start with an apology to each of you and maybe save a couple of you. Here's the apology. It was really my intent before tonight to contact each of you personally to let you know about my upcoming retirement. So I did reach a few of you before this evening. I did not reach all of you, like I said, the way I intended to. Some of you, I think, may have heard word of my retirement by way of a press release from Centerstone, but I really wanted to make it more individual and more personal. So I have announced my retirement from Centerstone. It'll be May of 21, so there's still a bit of time left between now and then, but just wanted to share that with you this evening as well, because word is out. I'm also in a position to let you know that my current Chief Operating Officer, Ben Middleton, who's been with Centerstone for nearly 30 years, will succeed me as CEO in May when I retire.
No, you can't go. It's an order.
To that, I'll say thank you. Yeah.
Bob, we're so grateful for you. Thank you for the leadership that you've provided to this council. It's meant a lot to all of us and your many years of leadership for this community. What a difference that you've made for so many. So congratulations.
Jameson, thank you. Thank you. Lots of memories. Lots of gratitude, lots of memories.
Bob, from one retired guy to a soon another retired guy, enjoy it and have a good time, and you deserve it. And everybody's going to miss you, but enjoy your retirement.
Dan, I hope to stay as busy as you are, so I'm going to come for some good mentoring.
Oh,
You know, I'm not going to give up this work. I can't give up this work. I don't want to give up this work, right?
yeah.
I am going to grab my life coach, and my wife have both said you better take 4 to 5 months, right, of not making any commitments, get some downtime, and then do what you want to do. So I'll come for some mentoring and some coaching.
Well, thank you. You've been so inclusive and very thoughtful when you've done work such as this, and to make sure that everybody's heard. And I really have appreciated it and have appreciated knowing you. Maybe not so closely, but through the years. Thank you.
Thank you, Robert.
Yeah.
All right.
Bob, you had mentioned transitions, and so on that front, I want to share with you guys that I will also be transitioning from my role at Vanderbilt Behavioral Health, and will also be able to have the great gift of watching our Chief Operating Officer, Mary Polakowski, assume the role of president for our services, and I'm very, very excited for her and the impact that she's made. She's very close to most, if not all of you. And so I know that you know that we are in great hands in the fiber of our team. Being very grateful for the support from everyone in pursuing this calling to continue to help to improve personalized care in behavioral health at a broader scale. Unfortunately, no services in Tennessee, but I will stay in Nashville, maybe on the road a little bit more than I have been, but to help address core issues for folks at a young age for long-term well-being in the adult years. So anyway, I'm grateful for each of you and the difference that you've made on this council, and I'm very proud of what we've accomplished here and the opportunity to serve alongside you in such a time.
Jameson, I love Mary. She's my board president, but I have so just personally enjoyed you. You've got such a big heart, and wherever you go, you're taking that with you, and they are so fortunate. And I do hope we'll all keep in touch, because you're a very special person, and I'd really miss that.
Thank you, Robin. Thank you so much.
I'll
Yeah.
I would say for both.
either one of y'all can go. That's a double order.
I'd just like to say both to Bob and to Jameson, your dedication, your insight, it makes me think deeper, it makes me think differently, and I think for many on the council, there are those that would share that, and just the amount of time that you've dedicated to this, think it would be difficult for people to understand how much time Bob has put in addition to the meetings and the other things that he's led us through with this. And Jameson, your contributions have been just so remarkable and so valued. I really was sad to hear your news, and but you both, will continue, I know, to influence things in a very positive way. So again, my congratulations to both of you, but again, kind of has that double-edged sword feel to it.
Angie.
Jameson, I'd be sitting here tonight really shocked if rumor hadn't gotten out a little bit before this evening. So
Yeah.
I appreciate being less shocked than I would have been, but again, just my recognition of your contributions and my thanks as well. And I hope, post-COVID here, life gives us a chance to share a beverage.
Oh, absolutely.
In a conversation. So thank you. All right. Can we I think we're through the agenda. And since we have to stick to our agenda, I really can't say, which I normally do, any other business for this evening, because I would be out of line. But let me again just say thank you. And again, Jameson, we will miss you dearly. Thank all of you. Our next meeting is February the 4th. I'm assuming that will be virtual again until things significantly change. We did a little bit of talk as we were prepping for tonight's meeting about some agenda ideas. We definitely want to carve out some time to give an update around the vaccine. We think that's going to be a perfect opportunity. We'll come back again, deeper dive on some of the survey data. Let us know what else needs to be on the February agenda from your perspective. It may be another opportunity to share among our group maybe we can do some quick round robin that evening on best practices coming out of COVID as we're thinking about what post-COVID care delivery looks like from each of our unique perspectives. Maybe we can do some of that in addition to these items, but please share your needs, your sense of community needs ahead of time as we're preparing for our February meeting. I will entertain, actually, how about by acclamation, motion for adjournment? I'll take it by head nod too. I see enough heads, enough hands going up. We are adjourned, and thank you. Have the happiest of holidays. Be safe, be careful, stay healthy. And all this will be behind us as we get into late spring, early summer, and I do look forward, I hope it's before May, but looking forward to getting together in person.
Yes.
All right. Thank you.
Thank you all.
Bye.
Thanks.
Bye.
Bye.
Good night.
Hi.
Night.